Hello, everyone. My name is Mike. I'm a physical therapist and your host of the Health Me podcast. Thanks for tuning in, and remember to leave a like and subscribe so you don't miss any updates. What's up, everyone? We are back with another episode for you to hear from an orthopedic spine surgeon revolutionizing what it means to get spinal surgery. The actual name of this new innovative surgery is called Awake Spinal Fusion, and I had the amazing opportunity to sit down with the man who completed the first one. You may have heard of awake surgeries before when they do craniotomies or so on, but to complete the surgery on the spine is actually quite amazing. During our discussion, we go over what motivated our guest to do the surgery in the first place and what it's like to be at the forefront of innovation. Next, we highlight the patient experience, running through the step-by-step process of consult to surgery, and talk about how this new surgical intervention is leading to less time, less medication, and money overall for the patient. Additionally, we go over the difficulties of becoming an educator and teacher for this new innovative technique, and how this ultimately led to the birth of a new social platform called Doc Social. Doc Social is delivering more effective and accessible digital health education to the world's physicians and healthcare providers. And as a member myself, I'm really excited for you guys to discover what this is and learn more about it. As always, all links will be provided below for our guest, as well as Doc Social, and be sure to comment what you thought of this week's episode. Here is my conversation with Dr. Alok Sharan. Well, you're an innovator in the orthopedic spine surgery space and kind of began somewhat of a disruption over the past couple of years by performing what's called Awake Spinal Fusion. I kind of wanted to hear from you. What was the original motivation for starting Awake Spinal Fusion?
Yeah, it's really interesting because when you look back, it seems like it's a very linear story. But the reality is, it's really just a conglomeration of different events that are happening in my life that really came to the situation. One of the first things that happened was I had to operate on an individual, a very prominent individual at the institution that I was working at. And he was in a situation where he was interviewing or recruiting somebody, and he really needed to be very mentally with it and needed to have spine surgery. He knew that when you have general anesthesia, that you have some cognitive issues afterwards. There's been enough research that's been performed that shows that after general anesthesia, there's issues with in terms of delirium and whatnot. And so he specifically asked for his spine surgery to be done under spinal anesthesia, which was a novelty for me. It was interesting enough because at that time as well, I was actually doing research with somebody, a girl who was doing her PhD, and she had done a really good job of doing some research showing that the incidence of delirium after general anesthesia is actually significant versus spinal anesthesia. So it was really those sort of two things that came together. The fact that he wanted to have his surgery done on spinal anesthesia. I was in the process of doing research showing that. And then my dad had heart surgery. And we know that after heart surgery, if you go on pump, people develop something called pump head, which is sort of issues with cognitive reserve as well. And so it's sort of a conglomeration of things that sort of came together and said, okay, fine, we should probably start rethinking how we do spine surgery. It was really those three things that came together, and we did the spine surgery, his specific spine surgery under spinal anesthesia, and it was amazing. And then what happened was, of course, like you do it once, you do it twice, and luckily I had a good team behind me, an anesthesiologist and whatnot. And we're like, wait, this is actually a little bit better. So then you say, okay, let's keep on going. And then one thing that really happened, which was really fortunate for me, was that I, fortunately or unfortunately, I ended up switching jobs and working in this private hospital with a group of anesthesiologists who had been doing a lot of work with fast recovery, ERAS, they call it. And I suggested to them that we should start doing all of our spine surgeries under regional anesthesia, under spinal. And they're like, of course. And so for them, there was no novelty about it. That of course, we're more than willing to do it. We understand the value of it. And that's when the program really started taking off. Because at the end, I know that, it's one thing to be a disruptor, but boy, it's so much better when you're disrupting and you have a great team behind you.
Well, certainly, especially if people are going to be like, who is this new guy who's about, doing something different? We don't want to mess up the hospital or at least the outcomes of it, because that ultimately dictates with how much money is coming in. And so if you're doing something new, I'm sure from an administrative point of view, it may be like, well, I don't know about this.
Yeah, it's interesting. And I think the point you raise is actually so interesting because I'm very interested in the process of innovation. As you probably saw, I got a healthcare MBA up at Dartmouth, and There are a lot of different courses you could take in business school, the typical finance and strategy, but I was really drawn towards the innovation classes. And I was really fortunate to get close to one of our professors who had studied innovation. And when you talk about innovation in Silicon Valley, they talk about fail fast and fail often. Well, if you're writing a computer program, it's easy to fail fast and fail often. Or they talk
Yeah,
about
right.
breaking
Easier
things.
said than done.
In medicine, you can't do that. In
Yeah.
medicine, you can't do that. And you're absolutely right that you want to always be doing innovation in a very controlled fashion so that you don't fail. And that's always been the challenge. And so I was lucky to really have a good team around me that sort of helped us push through.
Well, what was it like in the first surgery? I mean, you kind of brushed by doing something innovative. Like it was kind of like, oh, you do it once, do it twice, so on. I mean, what was the environment in the room like the first time you performed the surgery? I mean, was it kind of, another routine day? Was it something a little bit more high strung, more high stress situation in that instance?
Yeah. And I'd be lying to you if I didn't say it was stressful. It,
Yeah.
it was obviously very stressful, but it's like, it's like playing a new sport or going to a new place. Like you have to basically think it, practice in your mind, you simulate it, talk to everybody, and then you do it. What was actually interesting was doing a laminectomy under spinal anesthesia. That's been described before. That was interesting. But what was more interesting was when we did our first spinal fusion under spinal anesthesia. That novelty had not really been described before. But for us, it was really neat because the way I think about innovation is that you sort of have a series of steps, and then you change one step, and then you do that. What you never want to do is go steps A through G and change all the steps at the same time.
Mm.
So if it's A through G, maybe just change step F and see what happens. That's how I think about innovation. And so when we wanted to do an awake spinal fusion, by that point, my team was just very good at doing spinal fusion surgery as it is. Changing the type of anesthesia we do is just changing one step, and it almost seemed like there was no difference. And that's the way I like to do iterative improvements. Basically, just take one step, change that, measure it, improve upon that. But don't try to change too many things at once.
And I'm sure you had to be completely relieved that just changing that one thing had led to everything that you're doing right now and continued to innovate and build new things, because you could have changed the wrong thing or the wrong, letter, so to speak, and be like, oh, I got to go back to the drawing board, or perhaps there was a negative outcome in that way.
Exactly right. And that's the whole thing. And I think that what's challenging is this. I mean, look, innovation is just a series of disciplined experimentation. I think the problem with the difference between innovation and art is sort of, you can sort of fly by the seat of your pants. With innovation, it's about methodically trying to improve things in a controlled fashion. So you do it, you measure it. I can tell you that, as I give a lot of talks about awake spinal fusion, and you'll see that I have a very deliberate manner in how we basically improve. And we are constantly saying, okay, what's wrong now? Let's improve it, measure the results. Doesn't work? Let's try it again. Try something different. And I think that that's the best way of thinking about improvement of innovation. A lot of times people want to sort of do this sort of, shotgun and big improvements, and that's great. And maybe you'll get lucky. I'm not lucky. I just do things in an iterative fashion.
Yeah, I think as a as a clinician, sometimes you like to think that you're better than you are, and oftentimes that's probably the biggest bias that you may bring in the room.
Absolutely. And I think that medicine as a whole will advance when we have more people who are just doing very iterative type of innovations, not this big groundswell kind of improvement, dramatic shotgun or things.
Right. And you don't want to throw like the baby out with the bathwater, like every time. Like you want to just take these small incremental changes. And I'm assuming over time, that's when we're going to lead to the largest innovation and continue to grow as a profession. Because in physical therapy, it's interesting because, we're a little bit newer in the sense compared to like medicine, where there's still a lot of groundwork that needs to be laid down in regards to what we're doing. And so part of that is, seeing the same patient over and over again. And I had also, had found that just changing one part is probably more important than changing the whole thing, and
Right.
seeing like who can get better faster and sooner.
Exactly right. Yeah, and I think, and the other thing about innovation is that you've got to collaborate with other people to see what their results are too.
Mm-hmm.
So yeah, I think I find it better that, if you read about Thomas Edison and how he came up with light bulb, it wasn't that one day he had a moonshot and came up with light bulb. He had about 1,000 different attempts before he finally got the right one.
Right.
We always hear about light bulb, but there are about 999 other attempts that just didn't work out.
Well, it's more of the story behind it, right? Like you can have like the creation of the car wasn't exactly like all of a sudden we have a car. Like first it was, we have the dune buggy and horses, and then we have, first we had the tires, right? And then like we invented the wheel, and then we have, then we create these buggies, and then we have this, it it doesn't always look exactly the way that it's like something doesn't happen spontaneously, right? Like the
Right.
process of what gets you there doesn't exactly look like how you think it would have done.
And that's why it's got to be a disciplined form of experimentation. It's one thing to experiment, but you have to go back and look at your data
Mhm.
with that experiment. Absolutely.
We're highlighting just innovation, which I want to continue building off perhaps later. But maybe for those who don't understand what exactly spinal fusion is and maybe why you should get one, maybe just briefly describe that, and then also the alternative to awake spinal fusion that you're doing now.
Yeah, that's a great question. So, of course, as the population ages and we're seeing more and more of the baby boomers entering the later years of life, spinal conditions, as you know, is an increasingly prevalent problem. Probably the number two or number three reason why people see a doctor for any reason beyond just a common cold. So back pain, sciatica, pinched nerves are very common disorders. Thank God we have great physical therapists, of course, that can take care of these kind of conditions. And then pain management as a field is really evolving. So for the majority of people who have back problems, pinched nerves in particular, there's a lot of non-operative measures that can help. But of course, there are times, and the reality is that there are times when surgery is a better answer. For
Mm.
those people who have tried conservative measures, tried physical therapy, tried pain management, and even for those who just need to get back to work quickly, surgery provides a quick fix for the right patients. I've been doing spine surgery for 15 years now, and I'm still in awe of the outcomes that we get. I mean, people are in such pain, and when we go in there and do a surgery where we unpinch their nerves, by the next day they're perfectly fine. It's absolutely amazing. So it's about quality of life. So for people who have pain that goes from their back down their leg or from their neck down their arm, typical radicular symptoms, who failed conservative measures, including physical therapy and injections, spine surgery is a great option. Spinal fusions in particular, there's a lot of controversy around spinal fusions. I think, unfortunately, for a variety of different reasons, spinal fusion surgery has gotten a bad rap in the lay press. But for patients who have, let's say, an instability of the spine, so for example, the joints in the spine become loose and the bones become sort of wobbly. For those people, they need to be stabilized, and a spinal fusion surgery is an excellent surgery. Or for people who've had previous spine surgery and need to have another one, sometimes a spinal fusion surgery is necessary. So typically, when someone has a pinched nerve, I say this all the time. My goal as a spine surgeon, I unpinch nerves. So when someone has a pinched nerve, I unpinch them. I may unpinch them with just doing a simple operation called a laminectomy or a discectomy. But sometimes if they have a pinched nerve and instability, I need to do a laminectomy plus the fusion to stabilize them. That's typically what we do. Now, what was interesting about what we're doing though is a spinal fusion surgery across the country can be a 2 to 3 hour operation, and people stay in the hospital for about 2 to 3 days. And across the country, people are on narcotics for 4 to 6 weeks.
Mm.
What's been driving our Awake Spinal Fusion program is a few things, mainly because what we're trying to figure out is how to make a spinal fusion surgery an outpatient surgery. Basically, I always tell my patients that if I do my job properly, you should forget that you had surgery because the experience is so good. So at this point now, an awake spinal fusion is really just a combination of using local and regional anesthesia to do the spinal fusion surgery. It takes about an hour and a half to do. Patients go home within 4 hours. They're on pain meds only for 3 to 5 days, and they're typically back to work within 1 to 2 days. So the national average is people stay in the hospital for about 2 to 3 days after surgery. Our patients stay for 4 hours. The national average is to be on narcotics for 4 to 6 weeks. Our patients are on pain meds for only 4 to 6 days. And then I don't have good data about return to work, but our return to work data is about 2 weeks.
That's incredible. And for those who may not understand what outpatient is, it's just instead of going to the hospital, you're doing like going to a facility not connected to a hospital that will allow you to get surgery. And what are some of the benefits of making this outpatient? I mean, you've highlighted some of the stats where like people are returning to work sooner, they're going home sooner, they're having less, they're not on pain medications as long. I guess, is there other additional benefits from this being an outpatient surgery versus inpatient?
What's interesting actually is that because of COVID and for a variety of different reasons, a lot of people are just scared of being in the hospital.
Yeah.
They don't want to get an infection. Perhaps they don't like the food. But the one thing I learned actually, the most telling one story was this. When we first started doing awake spinal fusions, didn't really think initially about sending them home the same day. But I had a patient in her 70s. I still remember this story. Patient said, beautiful lady, really nice lady. I get a call like around 7 o'clock at night that she wants to go home. I said, she wants to sign out AMA, against medical advice. meaning that she doesn't care what's happening. She wants to go home. Long story short, she went home, and I said to her the next day, or when I saw her afterwards, I said, "Why did you want to go home? Like, why wouldn't you want to just stay in the hospital?" She goes, "Doc, look, I'd called for some pain medicine, right? And the nurses were busy; they're taking care of other patients, which I perfectly understand. And they couldn't come serve me till about half an hour later." She goes, "Look, if I was at home, I'd have been able to get up, go to the cabinet, and get the pain meds myself. So for me, it's about having control.
Mm.
It's for me about being able to control my own care." And I think that most people believe that. Yeah, there's some people who really want to have someone holding their hand, but I think majority of people, they want to have control of their care. So they want to be able to go home, sleep in their own bed, make their own food, take pills when they want to. They know enough, I believe. And so for me, outpatient is more of a mindset than anything else.
Yeah, and it must feel empowering for patients to be able to do that, because if you can go to a place, get a simple procedure, go home, and once again be able to feel like they're able to take care of themselves instead of like feel completely helpless.
Absolutely.
I can see how that would be empowering to a patient to continue, not only from my perspective, just to get up and moving and just start using your body the way that you're supposed to, but also just from a population standpoint, it'd probably be more helpful, so that way patients don't view like I have to be down for like several weeks and so on.
Correct. Yeah, I think that increasingly nowadays what we're seeing is more individuality
Hmm.
and in everything. And I think that patients in particular want to have more control of their health.
With your surgeries, one thing that you've talked about before, just preparing for this podcast, was that you allow for patients to kind of gauge how much they're in and out of the surgery in regards to just using the general anesthesia. And so that's also kind of the individual part that you're discussing. So maybe just highlight a little bit about going through the surgery. Perhaps a patient comes in, they're a perfect candidate, they're ready to go, they're somebody who's within the parameters for getting the surgery. What does it look like going from the consult to the operating theater?
Yeah, that's great. And so what's been really fortunate, what I really enjoy is I work in a practice where we have it's multi-specialty. So we have physical therapists, we have chiropractors, pain management, surgeons. So I get to see the patient multiple times. I don't get to see them only when they need surgery. I get to really see them sort of on their journey. And
Mm.
so what's been nice is for us as our practice is that we sort of say to the patients, let's not waste any steps. Let's collapse timeframes. So if you're having pain, let's go to the next step. Let's go to the next step. And so when the time comes for surgery, part of the outpatient dilemma, I think, is that you sort of have to mentally get into the head of each patient too.
Mm.
You got to get them motivated. You have to prehab them to get them stronger. You want to optimize them nutritionally. If you can do all that before surgery, well, their results are amazing. So when the time comes that they've gone through all the steps and they're ready for surgery, we spend a lot of time educating them about what's going to happen. We actually have a prehab program. So we actually work on them, working on their mechanics and their function to make sure they're stronger. We have a nutritionist. So we basically work on that too, as much as we can, to make sure their protein is good and their overall nutritional health is good. So we really try to optimize them. And then mentally, we say, you're going to do this. You're ready to go. I mean, our patients are some of the more excited patients to come to the hospital, which is great. And then we meet them in the hospital the day of surgery, of course, sign our consents and bring them to the operating room. We start by giving them the spinal anesthesia. And typically by that point, we start the twilight anesthesia. So they have no recollection really of anything that's happening. What's nice is with this technique, the patients are actually able to position themselves on a bed. And that's really nice because patients basically are going to be, let's say, prone for about an hour or two. And so they can put themselves in a position that's comfortable as opposed to me doing it for them. So they will adjust themselves. For females, they have to adjust their chest. And for elderly people who have shoulder problems, they can put their arms where it's comfortable. So it becomes a very comfortable experience because they're doing it themselves.
Mm.
And then we also do what's novelty about our awake protocol is that we do a fairly novel regional block where we sort of numb up the muscles around the back where we're going to do surgery with the medicine that lasts for 48 hours. And that's really been a game changer for us. So then by giving that block beforehand, they really don't feel much pain for 48 hours, which is the toughest part of any kind of surgery. Then we do our surgery. We do our surgery using minimally invasive techniques, which is a combination of small incisions and cameras. And then by the time we're done, which is about an hour and a half later, the patient is awake. We turn them over, bring them to the recovery room. It takes about an hour for some of the medicine to wear off. And about 2 hours later, we get them up and walking. And then about 4 to 5 hours later, we get them ready to go home. On our website, we have some videos so you can sort of see that whole journey about how within 4 to 5 hours they're ready to go. And for me, what I really, really enjoy is when the patients are dressed in their own clothes 4 hours later, and you can't even tell that they had surgery.
Yeah.
That's what we aim for.
I love it. I love to be able to have patient comfort. I love the idea of, just bringing the patient through prehab. I love that, of course, from my end. One question I did have
Yeah.
was, did this new surgical implication perhaps bring about more complications or things that you need to be wary of in order to perform the surgery? Being awake for a surgery, it's not very common, right? So are there things
Yeah.
that are maybe like contraindications that will prevent you from going forward with a surgery with somebody?
Yeah, there's no severe contraindications. If you are, of course, on blood thinners, you can't have a spinal anesthesia. If you have breathing difficulty like COPD, it's hard to lay prone for 2 hours. So
Hmm.
those are really the absolute reasons why we shouldn't do the surgery. But then, of course, as a patient, if you don't want to be awake, then that's something we have to deal with. Although most patients don't actually mind that, because when you talk to them about the twilight part, it's almost like having a colonoscopy. Or many of them have had epidural injections, and so they're very familiar with the whole notion of twilight. And so that part isn't that. To your question, though, what I think is absolutely fascinating is this. We do in orthopedic surgery, there's been a great movement with hand surgery, where they do a lot of hand surgery now awake. They call it WALANT, WALANT, wide awake hand surgery, I think is what it's called. In neurosurgery for the brain, they do awake craniotomies. So people are doing awake surgery, but I think what's fascinating is this. Here's another story. I had a patient who we're operating on, and he had gone for a couple of different opinions. I work in the New York City area, so it's very easy to get multiple opinions. And the patient ended up coming back to me. I said, okay. Obviously, I appreciated the honor. I said, why? He goes, well, you're going to do it awake. I said, okay. He says, I'm going to listen to music during surgery. I said, you're going to listen to music during surgery? He goes, yeah. Why not? I'm going to bring my AirPods in and listen to music. I said, okay. I'm game. Let's try it. And so he brought
Yeah.
his AirPods in, listened to music, and he finished the surgery and said, how'd it go? He goes, it was a beautiful experience. He said, I just did spine surgery on you. It's a beautiful experience. He goes, doc, I was on my belly. I was very comfortable. It was like getting a massage. I felt like I was getting a massage and listening to music. We turned the lights off during surgery to use a microscope. And he said, it was just a beautiful experience. And so it made me realize that when a patient is awake during surgery, you can have them listen to music. People will listen to podcasts. Maybe in the future, they could wear VR glasses and watch a movie, right?
Mm.
So you can really transform the experience when someone is awake. And I think that now what's going to be fascinating for us is as healthcare moves more and more into this experience economy, it's not just about giving good care. We have to all do that as a baseline, but how can we make it such a great experience that they'll want to go back and tell their friends? That's the difference, right? That's the Netflix story. That's the iPhone story. How do you make it such a good experience that they're going to go out and tell their friends? That's what we're thinking about now.
And that's the best form of marketing, right? Like for orthopedic spine surgery, marketing is a huge tool for you guys, because the more people that can say
Yeah,
word of mouth and other clinicians see success, they're obviously going to want to continue to come and see you, so that way
absolutely.
they can continue have better outcomes.
Yeah, I think so. And it's the way I think about it in healthcare is if you look at healthcare as an industry, like compared to, let's say, cars or even the phones, like we're a little behind because we're just touching upon the issue of experience now, right? But as you know, like the experience in a Tesla is amazing. The experience of an iPhone is amazing. So why can't we deliver such an extraordinary experience they want to tell their friends? What we do is so valuable. A lot of us know how to give good care. You do, I do. But why can't we make it such a great experience that they want to go out and tell their friends? We're not there yet, but I think when you start thinking about the awake patient differently, is when you can start doing things. You'll start seeing those kind of results and outcomes.
And do you believe the future of surgery, whether orthopedic and beyond, is going to be more in this realm of awake surgeries, or do you believe that there still needs to be a lot more innovation and questions to be asked?
I think the train has left the station, right? So this notion of using regional anesthesia in surgery, it's the train has left the station.
Mm.
The I have no equipoise about that now. There's no question that regional anesthesia, when possible, is a better way to go. The only question that we have now is how do we scale what we're doing? How do we get more and more people to adopt these kind of techniques?
And part of what you're doing now is teaching other physicians how to do awake spinal surgery. I guess, what has that been like to try to help other physicians try to transition into this new age of spine surgery?
Yeah, that's a great question because spreading new ideas in healthcare is always challenging, as you know. But during the COVID period, actually, I got a call from a group in Oxford, England, because the NHS system in England was just getting crushed with COVID. And as a result, over in England, some of the rules state that you can't do elective surgery if there's no beds available. And so they were not doing any elective spine surgery. So you can imagine people with foot drops severe spinal stenosis were just not having surgery. So the group from Oxford had called me and said, "Hey, look, we know you're doing this awake surgery outpatient. Can you teach us how to do it?" I said, "Well, we're sort of in this COVID crisis. I can't come to England right now." And so, using our virtual techniques and our technology, our video, I walked the group through how to do awake surgery for laminectomies primarily. Now, what was interesting about the NHS was this: their healthcare system, of course, is different on multiple different levels. But the NHS said, "Fine, you can do it, but after 10 cases, we want you to stop, review the data, and present to us. And if it seems like it's a good idea, we'll let you keep on going." And so the group did 10 cases. They collected their data really well. They presented to the NHS, and they were able to basically do, I think, 10 patients, all outpatient. Everything went great, such that the NHS said, "Now, this is amazing. We want you to go out and teach all the other hospitals within the system how to do this." So that was a lesson for me, that I can basically teach this technique virtually, right?
Mhm.
And so, as you know, we created a platform called Doc Social. The goal of Doc Social is to be the leading digital education platform in healthcare. Because if I can teach people in England how to do awake surgery, we can teach people all over the country and all over the world. And it's not just spine surgery. There are many techniques out there, cardiology, knee replacements, that can be taught. And there's people out there in Africa and Thailand, Australia, who want to learn this. So what we're doing at Doc Social is creating that platform where people from all over the world will be able to see what's going on and learn from our techniques.
Was becoming an educator something that came natural to you, being able to teach and be able to effectively um, basically show what you're trying to do can be often challenging for some people, just to kind of get their thought process out on paper and then also explain it in a way so that way people can fully understand it and digest it. Was there a gap between becoming a clinician to an educator?
It's a great question. I think that being a good teacher is so challenging. Being a good coach is so challenging. I started my career off at an academic medical center, so I was involved in teaching residents. I was named Teacher of the Year too, so multiple different times. So in many different forms. So I've always been around teaching. I do have young kids, so of course I'm involved in teaching them too. Being an educator is not easy. There's no question about that. Trying to understand what your student does not know is the challenge of education. Being able to teach people what you know is easy. Being able to teach them what they don't know and helping them see that, that's hard. But I think that if we're truly going to scale ideas in healthcare, we really have to start thinking about how do you educate other colleagues, physicians, therapists, nurses, like that. And we believe at Doc Social that we'll be able to do that.
And one thing you had mentioned earlier was also collaborative practice and talking to other clinicians. Is that another additional motivation perhaps behind Doc Social?
Yeah, that's one of the main goals. I mean, at our practice right now, as I told you, at NG Spinal Wellness, we have every other Tuesday, we host what we call innovation rounds or grand rounds, where all of us get on. We have physical therapists, athletic trainers, chiro, pain management, surgeons are on. So when we're seeing a patient, it's truly everybody putting their eyes on the patient. What we hope to do with Doc Social is, so with Doc Social, we have a section called groups, where we have providers, all different types of healthcare providers coming on board. And for example, like in the hospital, supply chain is a big issue. Supply chain is a big issue because there are the billing people involved, finance people involved, reps, doctors. And in the supply chain group, you can see these robust discussions among people who normally wouldn't be sitting around a table together. And so, yeah, with the Doc Social, that's our goal, is that social media is powerful. So we're bringing together people who normally wouldn't come together. So I think it's going to be a game changer for all of healthcare.
No, I'm curious just to think, it's kind of a question that popped in my head. Part of collaboration is obviously with many different clinicians and understanding, management and so on. But another part of this is like patient experience. I guess within Doc Social, is there an opportunity perhaps to include patients in on this information that maybe surgeons and other people are benefiting from?
That's a great question. That hasn't been our focus. Right now, it's more healthcare provider to healthcare provider.
Mm.
I think that there's a certain collaboration at that level. I think when you start bringing patients into the mix, it sort of changes your focus. So we haven't really thought about that at this point.
Well, how can providers get involved if they are interested in perhaps sharing ideas and talking to other providers?
Yeah, I think that's a great idea. So first of all, the website is doc.social, so doc social. You can go on; it's free, and then go on and create a group. And then when you create a group, you can invite your friends, invite other people to get on board, and just have robust discussions. It's so much fun for me to just sort of see the robust discussions that are happening. I think in discussions that wouldn't normally happen anymore. So yeah, that's been great to see.
Yeah, and I got approved for to be on there as well, so I'm going to be on there to help share ideas, hopefully here soon, and try and get everything on for the podcast on there, so other people can benefit from all the stuff that I'm
Absolutely,
doing.
for sure.
Yeah, I'm super excited for you to be doing Doc Social and just providing a network for providers to collaborate and talk to one another, because there's kind of a motivation of mine for the podcast, but to not steer too far away from awake spinal surgery. One thing that I wanted to ask you was, did you get any pushback, or have you had any providers who are being like, what are you doing, man? Like this, I don't know if this is something that we should be doing.
All the time. I like it with any kind of innovation, right? I mean, you don't want to innovate just for the sake of innovating.
Yeah.
You want to innovate because you're actually creating value. And so I've been really fortunate to have colleagues across the country and across the world who've been also doing awake spine surgery. We have surgeons at the Mayo Clinic, at Duke, at Vanderbilt, in Colorado, at UCSF, who are doing it now. And what's been exciting for me is that they're just validating what we're seeing. So it's not just me. So everyone's seeing it. So to me, I think that what we're doing with awake spine surgery is truly creating value for patients in a better way. And so we collaborate together, and then that circle is just growing bigger and bigger. And we'll host a conference. We have study groups. We collaborate. We meet every once in a while and talk about challenges. One of a friend of mine in Italy does a really innovative way of doing awake surgery where the patients are on their side, and he's doing fusions on their side called an XLEF surgery. But he's doing that awake, which I would have thought you can do. Two of my friends in Duke and in Colorado are doing awake robotic surgery. So they're using a robot while the patient's awake. And I was like, so it's just so amazing to see these like people who are just sort of innovating upon an innovation
I,
overall.
and again, like you said, it's got to be rewarding, but also encouraging to back up what you're exactly doing. So that way you feel like what you're doing is actually, providing an impact and changing the world. You're always going to have haters, obviously, of course, but I'm sure it's got to be reassuring in what you're doing and that you're heading in the right direction.
It's reassuring for sure. The validation, what's nice about medicine, the validation comes from seeing the patients. And so at the end of the day, when the patients are coming in saying that wasn't a bad experience, that's great. I remember when I first started doing awake surgery, we would often do like a laminectomy, let's say at L5S1, the lowest level of the spine. And then, a couple years later, they may develop spinal stenosis at the level above or 2 levels below, and they may need to have surgery again, or they may need to have physical therapy, or they may need to have injections. And so I would say to them, okay, hey, look, unfortunately, you developed spinal stenosis at a different level, which happens. Can I send you for physical therapy? Can I send you for injections? Like, no, let's just do surgery. I said, let's just do surgery. She goes, Doc, the surgery was such a great experience the first time. I have no problem doing it again. And that to me has been validation for what we're doing.
Absolutely. And I wanted to kind of get into an idea that may be a little bit more challenging, but you seem so humble and you seem so collaborative and so optimistic about the future. And one thing that I've heard from patients sometimes that they get referred from orthopedics is that sometimes they're like, I didn't like my surgeon. He had an ego or so on. I guess throughout this process of being an innovator, how have you been able to either manage that, or is that something that's not even in your radar to be able to manage?
I think that it's not something I'd manage, because at the end of the day, you got to ask yourself why, right? You got to know the why of what you're doing. And so is my goal just to spread my name out? Is my goal to make an impact? Is my goal to spread a great idea out there? I think that if you ask yourself why you're doing what you're doing, it's not an issue about being humble or being arrogant or ego. I'm sure there are people out there who think I am arrogant, who think I have an ego, but I know why I'm doing what I'm doing.
Mm. And you got to be confident too. And from a patient's perspective, I don't want to, at least I wouldn't want to walk into a room and an orthopedic surgeon being like, well, we're going to maybe try this. We're going to see what happens and so on. And so there's got to be some level of confidence being like, I've done this. This is something that I do. I educate, I innovate, and we're going to go forward and do this for you.
Yeah, I have a method. Right? I'm not reckless. We've studied this in a deliberate fashion. We constantly study this. As I said earlier in the podcast, we're constantly trying to improve ourselves. I always live with a simple rule, which is that tomorrow should be better than today. Today should be better than yesterday, and that's it. Just constantly improve, and that's okay. That's a fun part of life. That's how we look at it. So I'm always constantly thinking, okay, what can we do? What can we tweak here and there to make the experience a little bit better? And we're constantly looking at those small little tweaks, and so we constantly iterate. When we first started doing spinal fusion surgery, when I started doing it, my average length of stay was 2.3 hours. went 3 days. Then it went down to 1.6, then it went down to 1.2, and then it went down to 0.6.
Wow.
That doesn't happen overnight. That happens in a very iterative and a deliberate fashion,
Right.
right?
Absolutely. I guess what are the continuing barriers for awake spinal fusion? You're having such positive outcomes. You're educating people all over the world. I guess what are some of the things that are stopping it from happening? Because in my eyes, I'm hearing so many good things, and you've been doing this for years now. It's not like you just started doing this yesterday. I guess what are the barriers from people adopting this all over the U.S. and so on?
I think that there's a couple of things. I mean, why do people end up staying overnight in the hospital? Social support. So if they don't have some support at home, if they live on the third floor of a walk-up, those are significant barriers. I think that you can't ignore the economic incentive. There's definitely still an incentive for patients to stay overnight in the hospital versus going home the same day. So that's that. Of course, there's an education issue, and there's a psychological issue. I think that patients have to overcome the psychology. But like everything else, we don't go from 0 to 60 overnight. You sort of go in a very gradual, iterative fashion. And so, what I like to do is when people call me, I get people calling me, asking me, I'd like to do this awake fusion. How do I do it? What I actually try to do is instead of teaching them my program, what I try to really do is understand where they are in the learning curve. Are they doing outpatient surgery? And so they just need to learn how to do an outpatient fusion? Or are there patients staying in the hospital for 5 days? You're going to have a different discussion with those people. And so everyone needs to be brought along in a different manner.
Mm.
So in terms of scaling this, it's not everyone. I used to run track when I was younger. So not everyone's starting at the 100-meter mark or 200 meters, 500. You've got to figure out where they are in the race and then bring them accordingly. And that's the challenge about teaching people.
I'm sure that's where you're going to be finding the biggest issues, where you got to almost hand feed them to be like, this is how you're going to do it. This is the outcomes that we're seeing. And obviously, just continuing to push the name out there. One question I did want to ask you is like, what was the name? What was it like trying to think about the name of this surgery? Like we had talked about before, marketing is a big impact with orthopedics. And when I hear awake spinal fusion, people may be like, what's that? It may make people feel a certain way. And so was creating the name awake spinal fusion, or at least coming up with a name, something that had a maybe go to the drawing board and make sure that you're choosing an appropriate name for the surgery?
Yeah, and honestly, we still get pushback on that because the notion of awakened spine doesn't seem to go well. But there's neurosurgeons do awake craniotomies, so that word has been used before. As I mentioned before, my hand colleagues they call it wide awake surgery. So there's that. So we just basically iterated off of that.
Well, I want to know what you're most curious and excited about next. Like, part of your journey is of being an innovator is looking into the horizon, and you've kind of gone above the clouds now, and there's kind of, or at least you're in open field, and there's nothing in front of you. There's, it's kind of your pace of what you want to do. I guess what's next for you, awake spinal surgery, and so on.
Two things, yeah. There's two things. One is, of course, scaling the program, meaning teaching as many people as out there. So while it's nice that people call me, it's going to be really interesting to be able to teach people on the Doc Social platform. So I'm really curious to see how far we can go in terms of teaching people. And then I really enjoy seeing the innovation upon innovation. So when my colleague in Colorado does awake robotic surgery, I would never have thought that was going to be the case. So I'm really excited to see what type of innovations we're getting on top of this innovation. Those are really the two areas I'm really focused on now.
Yeah, I'm really excited about it. I'm excited to see post-op patients from awake spinal fusion. I'm excited to see other surgeons and other patients perhaps continue to see better outcomes. Because again, it seems like something new comes around not very often. And it seems like this is something that has positive outcomes, and patients are clearly doing a lot better than they were before with some of these spinal fusions. Again, some of the negative connotations that may have come with that surgery.
Exactly. And that's what our goal is.
Absolutely. Well, listen, Dr. Sharan, I really appreciate you coming on the podcast today to share so much about what you're working on in addition to Doc Social. I have 3 questions for you that I ask everybody at the end of the podcast. This is going to be the health me to health you portion of the podcast. And I gave you a little time to look at the questions so you're not completely unaware. First question, if you had the attention of everyone in the world for 30 seconds, what would you say?
I would say, don't be scared to innovate. Don't be scared to try something new.
And people are going to continue to innovate, and they're going to continue to do that. Second, what book do you recommend, whether a book you're reading now or in the past?
I'm reading Elon Musk's biography. I think that's very interesting to see how he thinks. Obviously, he's been pushing the innovations to the extreme. So that's been a really fascinating read for me.
Yeah. Is there a particular name for it, or is it just like Elon Musk?
I think it's called Elon Musk. I forgot the name exactly. Yeah.
Okay, that's okay. Last question: where can people learn more about what we talked about today from you, Doc Social, and so on?
Two places, www.awakespinalfusion.com and then www.doc.social.
Perfect. And again, everything will be in the show notes. So make sure to go down there and follow, and also join Doc Social if you're a provider or clinician. So that way we can continue growing a great network of people and clinicians sharing great ideas and becoming more innovative.
Thank
Dr.
you.
Sharan, thank you again so much for coming on the podcast today.
I really appreciate it. Thank you very
Of
much.
course.